So I'm not sure where Jeff is, but I'm Adam Greenbaum, one of the co-moderators, and it'd be good to get started right on time here because this is where all the learning happens, which is all the cases that we wish we had a do-over or some clinical pearl, and hopefully we'll have some time for discussions and people can ask questions. So let's start with Adnan, who's got in the leadoff position here, going to tell us some interesting things about.
Yeah, it's a vague title, right?
Yeah, really.
I took it that I could choose whatever I wanted, and so then I picked, what you guys all thought I would pick, which is a BVF case, a valve fracture case. So just to start with, if you haven't seen this, the point is that when we do valve-in-valve TAVR, the smaller the surgical valve, the higher the mortality, and we think this is related to patient prosthesis mismatch. I wanted this to be more nuts and bolts about bioprosthetic valve fracture, so I'll just start with a sample case. This is one of our first cases, a 21 millimeter Magna valve with severe degeneration and stenosis. The true internal diameter of that valve is 19 millimeters, and we treated it with a 23 millimeter core valve. These are the baseline hemodynamics. The mean gradient was 36, and the valve area was 0.8. And after valve-in-valve TAVR, the mean gradient was still 26, and the valve area only increased to 1.2, which is suboptimal to say the least. Implant depth is important. So, this was our implant depth. It's a nice high implant just like we want, but the hemodynamics are not good. And so we did a bioprosthetic valve fracture, and you can see the waist give there. So just, who's done this? Okay, not everybody. Good. So our final hemodynamics after fracturing the valve were a mean gradient of 9 and a valve area of 1.6, which is much better. And we published a little bit about this. These are 15 cases in which valve-in-valve TAVR was done and then followed by BVF. The baseline mean gradient went from 42 to 21 with TAVR and then down to 7 with BVF. The valve area went from 0.6 to 1.0 with TAVR and then to 1.8 with BVF. So it works. But how do we do it? We need to know a little bit more. We need to know a little bit about how valves fracture. So these are two fractured surgical valves, and you wouldn't know it by looking at it because the Dacron sewing ring remains intact. Okay, so that's important. There are no protruding elements when we fracture a surgical valve. You have to dissect the fabric to see that the internal, valve ring has fractured. If you look at a CT reconstruction, this is another Magna valve, and you can see that there's a single fracture point and that the rest of the ring is otherwise intact. And, so the nuts and bolts about how to do this. If you want to perform a bioprosthetic valve fracture, first we need to know if the surgical valve can be fractured. And this is a chart that we published that basically shows, that green is good. If it's green, it can be fractured. Red is not so good. But some valves can be remodeled. They can't be fractured, but they can be remodeled. This is a term I'm going to try to coin now. Okay, so BVR.
There you go.
Bioprosthetic valve remodeling. So certain valves can be fractured. This center column, these valves can be stretched. So the older CE valves, this new Inspiris valve, if you haven't seen it, has a internal ring that can be stretched. These older generation Paramount valves and the trifecta valve, the posts can be flared with a high pressure inflation. So some valves can be fractured, some can be remodeled, and then there's this last category, the Hancock 2. Don't try this at home. The Medtronic Avalis, the new Medtronic valve, these valves can't be fractured or remodeled. So remodeling, here's just a video. Look at this old CE valve and look at how much it stretches with a high pressure inflation. The waist is completely gone at the end of this. So this is very doable, okay? You just need to know what valve you're treating and where it falls in the spectrum. What you need is a non-compliant balloon, a large syringe, an inflation device, and a high-pressure stopcock. We have the little notation here that this is off-label. And then the setup is simple. So we hook the balloon up to the three-way stopcock, the syringe, and the inflator. We turn the stopcock onto the syringe, and we, rapid pace, and we do a hand injection to inflate the balloon, just like doing a BAV. And then when the balloon is inflated, then we're going to turn the stopcock off to the syringe, onto the inflator, and we're going to dial up the pressure to the fracture threshold of the valve that we're trying to fracture, or just to a high pressure if we're trying to flare the posts of a trifecta or stretch CE or an old Paramount valve. How do you know the valve is fractured? This is very important. The pressure will drop. Okay, so as soon as the waist gives, as soon as the ring fractures, the inflation pressure will drop suddenly, and one of two things has happened. Either the balloon has ruptured or the valve is fractured. And that is the most important thing. You shouldn't be concentrating on the fluoro or the cine to look for the waist of the balloon to release, because it can be very subtle and you'll miss it. You can look afterwards and see that. Sometimes you'll hear a snap, but you can't rely on that. So it's very important that you just understand that the pressure drop tells you you're done. Once the pressure drops, you turn the stopcock back onto the syringe, you go negative, you stop pacing, and then you can reassess. Because it is a long pacing run, and so you have to be cautious. I don't see a timer anywhere. So who are we going to treat? Patients who have smaller intermediate-sized surgical valves, certainly we know that they benefit. We've published some hemodynamic data, but we need longer-term outcomes, certainly. What constitutes a small or intermediate-sized valve? I think that depends on who you ask, but in some studies, a 21 millimeter or smaller internal dimension is categorized as small or intermediate. Certainly patients who have a high residual gradient following valve-in-valve TAVR may benefit. Prior studies have defined severe patient prosthesis mismatch as a gradient greater than or equal to 20, but I'll tell you that our threshold is much lower to do this. Very common to have a gradient of 9 or 10 at the end of the case. You're happy, you're pleased. The discharge echo is a gradient of 18. Your 1-month echo has a gradient of 23, and now nobody's happy. So we have a low threshold, with our experience of doing BVF or BVR to optimize the hemodynamics during the initial procedure. Might all patients undergoing valve-in-valve TAVR benefit? Well, by facilitating optimal THV expansion, BVF or BVR might improve leaflet function and THV durability regardless of the surgical valve size or the residual gradient. So it's a possibility. We don't know the answer. When should we not fracture a valve? Well, again, we just need to know which valves we can fracture or remodel. If we have concerns about the anatomy, we need to know the STJ size, the LVOT size. We need to look at the coronary artery distances and assess our risk for coronary obstruction. And if coronary obstruction is a high likelihood, then maybe we need to protect the coronaries. We could do basilica. Maybe we ought not to fracture that valve. Although, I'll be honest, we have protected a coronary, fractured the valve, and then stented the left main, if the hemodynamics were poor after valve-in-valve TAVR. Ensure that the anatomy can accommodate the balloon that is going to be used. Assess the size of the STJ and the LVOT. Smaller balloons can be used, but higher pressure may be needed to fracture the valve if, the smaller you go with the balloon. Balloon position. So if we're going to put a core valve in, and then we're going to do a high-pressure balloon inflation to fracture a valve, then we need to be careful. We need to know the waist of the core valve, and we can't disrupt this waist, otherwise we'll injure the valve leaflets and cause severe AI. It appears that you can use a balloon 2 millimeters larger than this waist and be okay, but larger than that, you're at risk. So for example, in a 23 millimeter Evolut, the largest balloon you'd want to use is a 22 to do a BVF or a BVR. We also keep the balloon a little lower so that the shoulder is ideally below this constrained waist. Unanswered questions: is it better to do BVF before or after TAVR? This could be an entire debate, so I'll just be brief. Doing a BVF first, we're avoiding a high-pressure inflation inside the TAVR prosthesis, and maybe that avoids either acute or subclinical leaflet injury down the road. The con is that we might risk embolization or severe AI by tearing degenerated leaflets. TAVR first, the pro is that we can assess the hemodynamic results before deciding on whether to do BVF. The high-pressure inflation ensures optimal expansion of the TAVR prosthesis, And the con is that the high pressure inflation could injure the THV either acutely or subacutely. So just a couple more things real quick. So we did this on the bench. If you fracture a 21 millimeter Magna valve and then you put a 23 Evolut in, it expands pretty well. You get a diameter of 22.9. Okay, this would be the correlative, doing BVF first, then TAVR. But if you do it with an Sapien, that's an XT, so you fracture the valve, you implant the Sapien using the Edwards delivery balloon, and you only get 22.3 millimeters. It doesn't really get to 23. To get it to 23, we had to do a high pressure inflation with a non-compliant balloon. So doing BVF last may more fully optimize the expansion of the THV. We need to study that more. So in summary, valve-in-valve TAVR in small surgical valves may be associated with increased patient prosthesis mismatch and higher mortality. Most prosthetic valves can be fractured or remodeled with a high pressure balloon inflation, and BVF results in lower residual valve gradients and larger valve areas after valve-in-valve TAVR. Thanks.
Incredible. Adnan, one quick question. What's the maximum you think you can stretch these? How many millimeters will it go?
Yeah, so I took that slide out because it's complicated. So the maximum is 3 to 4 millimeters on the bench. All we tested on the bench were 19 and 21 millimeter valves. And to be honest with you, we didn't test every valve to see how much it could stretch. But I think 3 to 4 millimeters is reasonable. The next question then is, so what size THV do you put in? And that's, I don't know that exact answer. Is it, so for example, let's say you have a 23 millimeter Magna valve that has a 21 millimeter ID. Is it better to put in a 23 millimeter, S3, for example, and fully expand it to 23 millimeters, which is only 2 millimeters above the ID? Or is it better to put in a 26 millimeter S3, and you can probably get that to 24 and a half millimeters, but it won't be fully expanded. Long term, which is best, I don't know the answer.
But it's still important for the coronary.
Oh, absolutely.
Like if you can measure your sinus and you got 4 or 5, then you're probably safe. But
yeah.
Incredible work. All right, let's move on to Dr. Zajarias, who's going to show us his most humbling TAVR, which is, we've probably all been there.
I'm going to replay Adnan's slides now. So thank you for coming. The case actually is an interesting case. I work in a large center that has the advantage and the disadvantage of having a very large heart failure service. And as a result, we happen to see a lot of patients who have had transplant or are being considered for transplant or unfortunately have other therapies that they've been submitted to. So this is a case that is off-label, so just as my disclaimer. So this is a case of a 48-year-old woman who has had pericardium cardiomyopathy after her third child. And in November of 2014, she actually had a HeartMate 2 as a bridge to transplant. And 4 years later, she was still doing relatively well, and she was being evaluated for transplant once again. However, it was noted that as her EF had continued to decrease, she had significant aortic insufficiency. And once again, as a transplant workup was being performed, it was noted that she had a very reactive cytoscreen. So we met her in the ICU. Her 3 children were there. She was a fairly active individual, somebody who really want to go above and beyond the call of duty. So we really took a lot of effort in trying to make her better. She was in shock when we saw her. She had been developing acute kidney injury and acute liver injury. Her INR was now greater than 9, and she was requiring increasing amount of hemodynamic support. This is what her echo looked like, and as you saw, her ejection fraction was very much diminished, and she had a continuous torrential aortic insufficiency. So the amount of output from the LVAD that was basically circulating had been worsening over the significant amount of time. So we all sat down around the table and tried to decide if we're going to offer surgical valve replacement. The transplant service had decided that she was not going to be a transplant candidate in her current state. They were not going to take her to the operating room to try to do surgical valve replacement or aortic valve closure. And then potentially the ball was sent to us either to use a amplatz scribiform device or potentially a transcatheter valve replacement for the treatment of aortic insufficiency. Somehow we decided that we were going to do transcatheter valve replacement, and that's basically what we're going to be talking about. The problem was that, one, we didn't have a CT scan. So with the management or the magical hands of our cardiographers, we were able to devise that potentially at the level of the annulus, the perimeter was somewhere around 85 millimeters. However, immediately underneath the annulus, the LVOT just funneled out like a complete circle, and it was almost close to 95 to 98 millimeters, which posed an important limitation. The other thing that we were obviously very much aware was that there was no aortic insufficiency. There was a fair amount of aortic insufficiency with no aortic calcification. So as a result, in order to guide the procedure, we decided that we were going to use 2 pigtails to mark where the annulus was, and we're going to basically go ahead and try to place a 34 Evolut R, as we had attempted to oversize it as much as possible to try to gain both the annulus and the LVOT. We had a large discussion with anesthesia and the transplant service. Everybody was in the room getting very, very excited, or not.
Excited good or excited bad?
Excited.
Excited.
So this was one of our first cases that we had done a valve for AI, and we figured that we're going to decrease the RPM of the LVAD in order to minimize the sucking effect, quote unquote, of the device, and slowly attempt to deploy it. So we decreased the LVAD to 7,000 RPMs, and we started deploying in what we thought was relatively well, and the valve immediately just went down. And the patient tolerated well the first time, and then we decided that we're going to go back and do it a second time, and the patient did it okay the second time. But by the time the third time came along, her right atrial pressure now pretty much increased to the mid-30s. Her systolic pressure dropped to 50s. Her PA pressures were now greater than 70s, and her mixed venous sat was down to 30%. So by that time, the transplant surgeons were not very happy, and were actually about to place her on ECMO or something of that nature. So we increased the RPMs one more time, and we figured that this time around, we were just going to do it at a normal speed. So either we were lucky or everybody provided the right amount of traction, but we finally were able actually to land the valve well and deployed it for at least at the 80% level. And immediately as we did that, the SVO2 increased to 60%. And as you can see here, there was just a trace amount of aortic insufficiency still when we were not fully expanded. We went ahead and deployed it completely, and this is what our end result looked like. The valve was fine, and it actually stayed in place. And actually, the patient went home 3 or 4 days later, immediately came off of all of the inotropes, and that was incredibly satisfying, particularly when we were able to tell that to the family. So she did go home, and we saw her in follow-up actually 6 weeks ago, and she was doing very well so far, still in the process of being evaluated for transplant TAVR. So the treatment of LVAD-associated AI is difficult, and I think there's many options out there. TAVR may be a reasonable option in selected cases. You definitely have to oversize the prosthesis. However, how much of it, we don't really know yet. And then anchoring the device is limited due to the absence of calcification, annular dilatation, and the LVOT widening. But importantly, we learned that altering the function of the LVAD during the procedure may limit the migration, but definitely may create hemodynamic instability. So by a rule now, we actually don't do that. And so far, we've had actually much easier and or better results.
This was tough. I mean, last year I showed a case of an LVAD that we actually put 4 valves in because it's so difficult. That was with the legacy core valve. So what was so amazing with this case is that the Evolut, it seemed as if you had better repositionability and you had more control. The other thing that we've sometimes done with these AR cases is actually pace fast, almost pace like Sapien pacing when we're trying to deploy it, just to make sure that it stays in place. Because you've outlined the fact that if you go slower with that and you're not in the right place and it's actually going to the ventricle. I think it's a fabulous case. Very, very nice. Any other comments? How many have done a case like this where they're tough, right?
Sometimes you can go for the carotid hangs off of there. A lot of these heart failure people have big vessels, and it's not a real threat, and so you don't have to worry about that energy loss in the arch. It's just hanging on a stick.
Yeah.
That'll make it a little easier.
And that's actually what we did. For the final deployment, we had the person up front was definitely, position 1 was pulling hard. Yeah. And actually was able to maintain it in place as everybody else was beginning to deploy it.
Yeah, good. All right, that's great.
Thanks.
Perfect, thanks. So our next discussion. I have to just get on my map here. So this is a great title. I wish you'd sent this patient to surgery, Dr. Malaisrie. So, how do I say that? Malaisrie. Malaisrie, thank you so much. Thanks. Escape.
Okay.
And then your name will be there, and you just double click it. And then to start. Thanks, Chris.
Well, good afternoon. I'm Chris Malaisrie. I'm a cardiac surgeon at Northwestern Medicine and faculty at Northwestern University. Thanks, Dr. Saraja, for inviting me. Thanks to the panel for putting up with a cardiac surgeon at the panel. So wish you had sent that patient to surgery. This is going to be an aortic valve and valve complication. I call this this is forever memorialized in my brain as the TAVR case. So rich emotional experience. Okay. Lots of disclosures. Here's the case. So she's 73 years old. She's had a bicuspid aortic valve in the past and previously underwent an aortic root replacement, a valved conduit, so a 23 millimeter bovine pericardial valve and a 28 millimeter Dacron graft in 2004. She's having symptoms. She's got some comorbidities. She's got severe aortic stenosis, and other valves are okay. Coronaries are fine. STS is 3, frailty is 1. We thought she was high risk for preoperative AVR because it was a previous route. It was a little bit harder to do. So pre-op CT scan shows a fairly tortuous aorta. We do these cases under monitored anesthesia care, so no general anesthesia, hybrid CCL anesthesiologist in the room. It was a tough case to get around with the Medtronic valve. We switched the Confida to Lunderquist wire, finally got it around. So this is about 80% deployment here. So it's a 23 peri mount. We're trying to put a core valve 26 in. I'm doing this with Mark Ricciardi sitting at the back table over there, grinning, I hope. So we're at 80%, and the implant depth is about 10 millimeters. We're pretty happy with this. So we go ahead and deploy this valve. It's moved a little bit. Now we're about 1 millimeter deep, and we're still pretty happy with this. We're letting the fellows get some gradients, and we're planning for a second case, and we're not happy with this one right now. So we're about minus 10 depth here, and of course, right about this time, you wish the patient was under general anesthesia because she says, "Oh, doc, my back hurts now." So just some mild AR. We pull her off the fluoro scan and take her down to CT, and of course, there's an aortic dissection here with a contained rupture. So we take her back. This time, general anesthesia, hybrid OR.
Where do you think the rupture was?
I think it's...
Where does that plan on your aortography? Because I don't see it on the aortography.
I don't see it on the aortography either, but I think it's as we're pushing the catheter around the descending aorta. So you got that S-turn. It's happened that S-turn just distal to the left subclavian artery.
So you don't think the migration had anything to do with it?
No.
I mean, the valves.
The Evolut has a nitinol shaft to it, and then it has a little nose cone. And sometimes coming around a tortuous arc, there's a little bit of a separation that can hit. That's why I was wondering if it was kind of right at the great vessel takeoff origin there.
Right, right.
And then the next generation now that's all on our lab shelf actually has tightened up that nose cone nitinol capsule separation, so it won't separate anymore. But I didn't mean to interrupt. I just think it's a great example.
So we take her back, we put this Gore C-tag in, and we're doing this whole case. The wire's in the LV because I want to get some support here, and just hoping that valve doesn't move anymore. So we're able to deploy this as a zone 2 landing. Pretty happy with this deployment. We've got 2 devices in there right now. TE shows it's more like severe AR now, so we go ahead and put a second valve in. We don't want to make the second mistake twice here, and I'll tell you why I think this happened. So we go ahead and put an Sapien 3 in. Pretty happy with this deployment. Now you see 3 devices in there. So she does okay. She's got this funny configuration now, 2 valves in series. You guys can explain to me how this is bad for the coronary circulation diastole. But in terms of indications, this is what guidelines say right now for a failed biprosthetic aortic valve and valve. So the patient's high risk or prohibitive risk, Europeans would call it increased surgical risk, class 2A recommendation. And I think Dr. Chattrawalla talked about this. The downside with valve and valve is gradients. So out of both trials here, both Sapien and the Medtronic trial showed mean gradients of about 17. So those are the, no one seems to believe me when I say that, so I have to show this slide. And Danny, it's too bad Dr. Dvir is not here, and it seems to be worse in smaller valves, maybe worse in the Sapien valve. AUC criterion just came out. Bob Bonnell authored this one, and valve sizes are coming into play here, and you see that the default is always redo surgery. That's always a green light. But if you got a valve 23 or greater, it's probably okay. It's always appropriate, never appropriate for 19 or less, and maybe appropriate for 21. So I think the indications are correct. But the big question is, well, why does this happen? I think Mike Reardon can understand this, but you got to respect the valved conduit. So on the left side there, you can see that there's a Dacron graft, and it's a little bit short. And distal to the Dacron graft, there's a mandatory anastomosis there. It's a little bit slightly dilated. And that conduit's a little bit short for this particular patient. And you can actually see what's going to happen here off that angiogram. The anastomosis is the valve is not sitting all the way into that conduit. So what's going to eventually happen is the waist of the core valve is going to find that middle anastomosis, and that's what I'm trying to show you in that last picture all the way to the right. So I think that's why it's migrated. Be glad to take any comments from the floor. But in conclusion, I think this case proceeded according to guideline recommendations, high risk and prohibited risk. Alan Zajarias is trying to study low-risk patients with a valve-in-valve trial with an Edwards Sapien 3. Complications here, we had a valve embolization, and we'll throw in a little bit of aortic dissection and rupture. So the treatment was a TAVR, TAVI case. The key learning here is respect that valve conduit in patients who had a previous aortic root replacement. And if you ask me if I would have done this surgery, I probably would have still tried to do a TAVI for this case. But I know what the hospital would say, though. Well, guys, you spent about $75,000 of equipment. Next time, operate on this patient, please. Thank you very much.
I found there's often a kink. Sometimes, I don't know, maybe if it's not done correctly or whatever, there's often a kink with those conduits, and sometimes the core valve, you have to almost guess at how it's going to lie in there and whether that's going to leave you canted sometimes. But
So the question I had was that you had a CT scan and you saw this thing, so why core valve? Why didn't you put a Sapien?
We wanted to do core valve because we thought we'd get better gradients out of it. And we didn't pay enough attention to the length of that Dacron.
Because it is, as you would have done with the post-dilation, you could potentially get very similar gradient. You just showed the data showing that both had similar gradients. So the question, because of the flexibility of the delivery catheter, sometimes if the aorta is so tortuous, I prefer not to use. And if you have a constriction on the top of it, again, the same thing, you could have potentially predicted that the core valve will not expand, as you say. And with the kinks, so many people have kinks with the Dacron ascending grafts.
So a couple things. We used a lot smaller, I think the valve sizes, was a lot smaller with the Evolut and our Evolut continued access or expanded use study. So I don't know if we can line up gradients per gradient because we'd have to look at the size of the valves, which might be different. But second thing is the Evolut doesn't require to have any contact to the aorta whatsoever. So I think that there's something that was going on at the inflow, at the site. It looked like there was a little bit of an incomplete expansion at the inflow down in the valve, and unless there's full expansion, you don't get the full radial strength of that. So I think that the problem was really at the surgical valve inflow interface with the Evolut, and not because it will sit right in the middle of the valve, and it doesn't have to touch anything. So I'm not sure that the interaction with the aortic root or with the aortic graft was a big problem.
And it does. It looks curved in. Because we've deployed them on just leaflets only, not even, they've often been like -2 and they stay. So it does look a little funny at the
And
bottom.
it was
I'm not sure.
moving a little bit outward too. So Mike, what do you think?
So, a couple things. First of all, that's a really funny looking graft. You almost never have to do a root on a bicuspid valve unless it's a young person with AI, not an old person. And usually that's when you do an ACE in the aorta. And somehow only half the ACE in the aorta got replaced. So it starts off, there's something wrong when you look at that picture as a surgeon. And the second thing is Chris, there's two ways you can do these valve conduits. One is you can put the valve up in the graft and leave a little graft hanging down. And so the graft to the annulus, or two, you sew the graft to it, you sometimes can just replace the valve and put things back in. You know how it was done, Chris? Was it done where you're going to have to do the whole root? Because these can be really complex in these old people.
Right, yeah, this surgeon put the sutures through the graft as well as the valve. So I knew this was going to be a tough redo.
Great.
Good, thank you.
Thanks. Let's, next we have Samir Kapadia. You're going to tell us how you managed a difficult Sapien case. They're difficult?
I know,
Yeah, are
that
there
is,
difficult Sapien cases?
So this was a tough,
You've had to find them.
thing to figure out, that a difficult Sapien. So I was telling that in the morning that there is no difficult Sapien, because if you are difficult, you have to be somehow missing something. That means that you messed up, because otherwise, if you plan ahead of time, it shouldn't be difficult. So this is my disclosure to begin with. So, this is an 88-year-old, relatively healthy gentleman. So that's why I'm showing you everything to see if you can figure it out. So cath, normal coronaries, echo, labs, relatively normal creatinine. Here is the cath. Again, you can see that the valve is super calcified, as you can see. And you see the right and the left. Again, see the valve. Valve is very calcified, normal ventricle. I show you the CAT scan, again, to show you that how the aorta looks. Valve is calcified. I even show you the valve. Valve looks like bicuspid. There is a right and left fusion of the valve. The valve, is an 88-year-old valve, and it is a calcified valve. So we saw all of that, and we measured the valve. Coronary heights are good. Annular size is large. It is 7 or 4 millimeters square, but it's not horrible. And so we thought that we can put a 29 millimeter valve in this patient, and relatively.
Did you do annular or supraannular sizing?
Annular sizing. So annular sizing, 7 or 4. So because, again, the good question from Dr. Popma to say that whether you want to size it for a bicuspid valve a little bit higher or lower. But for the Sapien, I like to size them at the annulus. So here, this is our standard. So we do same access. So I put a arterial sheath, and underneath that, there is another arterial sheath. We put a sentinel device, calcified valve, conscious sedation. I don't use predilation, but this valve is coming at an angle, and it is, it's very super calcified. And when we crossed the valve, we had a 100 millimeter gradient. I said, let us not, try to cross directly. Let us just dilate it. So this is unusual for us because we would not have dilated. But while we were working, I felt that maybe just we should dilate.
I think bicuspid horizontal root is, we do that too. I think that's a
Yes,
good
I know
idea.
it looks
'Cause
tight.
you could rupture the root by
Right,
trying
and
to
it
push
is a little
things.
bit tight. So, and you see it's very tight. So this is a 23 millimeter balloon for a 29 millimeter valve. Normally, of course, in the Edwards kit, you will have a 25 millimeter balloon, but I put a 23 millimeter balloon.
Do you ever use the movement of the calcium with the predolor to see if you're going to obstruct coronaries?
Correct, we do, but then you would like to see it in the LAO projection. This is in the RAO projection. But we have a biplane lab, and I'm just showing you the RAO, but we had a LAO projection. So so there was no coronary close by. The only reason I show you the coronaries is to show you that what is the axis of the aorta. So the aorta is fairly horizontal. That aorta, it is hard to see it on the x-rays, and that's why I drew a picture in the CAT scan to show you that how the aorta comes when I do the gaining properly. You can see the aorta, and it is horizontal at the end of it. So now we put a Sapien valve, and it will not just cross. It will not just cross. Bend it, turned it, flexed it, and we do fair number of them, but it just doesn't want to cross. So it reminded us of the Sapien, old ones where we didn't have a nose comb, and it will not not cross. So what can you do? So we said that, okay, we get a contralateral access of the groin, cross the valve, dilate with a 25 balloon. So pre-closed, put a 14 French sheath, dilated with a 25. Cannot do it. So now we thought that one option is to remove because valve does come out. So 29 millimeter valve will come out back through the sheath. It will not come out all the way through the sheath, but it will come inside of the sheath. Then you can remove the sheath. You can either get a new valve, or you can push the valve out, open it up, and crimp it back on the balloon, whatever you like. I've done both ways. But I think if you can afford it, and the Edwards would pay for it most commonly, then you can just get rid of the valve, get a new valve. Doesn't matter. But that is another option. And the third option is to go through the transseptal, snare the wire, try to change the orientation. Go ahead.
I think the other thing you could do is like when we go from radial and you can't pass the guide as you use balloon-assisted tracking, you could blow up that balloon on the Sapien at the tip and pillow it across.
It is a good point. You got to have guts, because if you do that, then it is a one-way road, a one-way street. Yeah. Because once you start inflating it, and then, because we had, so for the 8th case we did with the Sapien in our life, 2007, we did that we got so frustrated, so we snared the wire from the atrium, cannot cross. So then we said, now, instead of not doing it, let's have a bumper idea that have a little inflation. We inflate, push, and then the valve wants to come backwards. Then we dragged it down, deployed it in the descending aorta. It can be lucky. So what we thought that the only difference in this one, we then came up with this new idea that let us use it as a bumper balloon. So the reason why it's not going is because there is just a lot of space inside of the sinus. So instead of inflating the balloon in the valve, let us inflate it in the sinus. And so that this Sapien just can't go there. And then we push it on the balloon. Hopefully it won't rupture. So we inflated the balloon in the sinus. Patient was obviously stable. And then we just used a bumper balloon technique. As you can see here, it was actually extremely easy. So this was just out of frustration. We came up with this idea, and it worked well. And then finally, after that, we put 1 more cc of saline inside and inflated. And as we always do, we like to put it a little bit close to the annulus. And then finally, we went put 2 more cc's and inflated. So it's a large valve, and then looks very good. We didn't need a pacemaker. And here you can see we removed everything, and patient did actually. I have a sentinel removal too there, because we use sentinel in all patients. I didn't check in the sentinel filter, because normally we don't see much, and it's a waste of time, so we didn't check it. So instead of using a balloon, we use a bumper balloon, and that was the idea of this case. Thank you.
Great.
All right, so our next presentation is on a difficult Evolut case with Dr. Zahr, Firas Zahr, but we couldn't find one, so we have to skip this presentation.
So my little disclaimer, I was trained by Samir almost a decade ago, and I'm presenting a similar case. I'm much younger than Samir, you can tell.
Doesn't seem that way, but
And I'm presenting.
I'm just joking.
So the son of your patient came and said, well, we heard Dr. Kapadia never had a difficult case. I have a bicuspid valve and I want a core valve. So 43-year-old male, history of bicuspid aortic stenosis, presented with cardiogenic shock and respiratory failure. And he was really sick. He rapidly deteriorated despite being on a ventilator. It was difficult to ventilate him, oxygenate him, and he quickly became more hypoxemic, hypotensive. We placed him on a VA ECMO via the right femoral artery and vein. So this is his echo. I hope it plays. You know, very bulky calcified valve, and this is his ventricle. And as you can tell, his ejection fraction is severely reduced. Despite that, we got a mean gradient of around 80,
across that valve without ejection fraction, and he had probably around moderate AI at most. So we put him on ECMO, and the goal was to tune him up for TAVR. First 48 hours, we were unsuccessful. He was heavily dependent on the ECMO, more vasoactive support, his troponin, and peaked up to 705, despite the fact that he had a normal coronary angiogram. And so took him to the lab, his creatinine started bumping. We put a catheter in his left ventricle, and despite being on ECMO, being aggressively diuresed, his LVEDP was 40. So at that point, we were stuck. It's cardiogenic shock, troponin on the rise. We're not sure what was happening. We decided to put an Impella CP from the right femoral with the idea of venting and unloading the ventricle. We did not do valvuloplasty. I know Jeff is going to ask me, to do valvuloplasty around the Impella, and we were worried about the AI. We did not think that we can tolerate any complication. And at that point, his STS mortality risk was around 36%. We scan him, and it's a very bicuspid valve, calcified leaflet. Perimeter around the annulus was around 96. And another question Jeff is going to ask me about supraannular sizing. If you do supraannular sizing 5 millimeter above the annulus, you get a perimeter of around 82. So if you do annular sizing, if you do supraannular sizing, you're talking about 34 millimeter core valve if you want to do it. And you see the CT, you see the ECMO cannula, his ST is around 30 millimeter. So we put the Impella, we decided to watch him again, and despite that, he continued not to do well. He stopped peeing, his creatinine started going up, and we discussed his options, and we decided that we're going to proceed with a 34 millimeter Evolut, and we're going to use the left radial for the pigtail and the Impella site for the valve. So this is the Impella in place. The valve is bulky and is heavily calcified, as you can see. We pulled the Impella out, and we put the Evolut in, and we did not have problem crossing that valve, luckily. This is a problem that we did not want to have during this case. And actually, it was very interesting. We ramped up the ECMO flow up, so it's kind of like we're doing rapid pacing. There was very little contractility, and the valve deployment was very steady. As you can see, we unsheathed that valve pretty quickly, and we had a functioning valve. Now, the only thing is the valve looked like this. So the valve looked like this. And we did not pre-VAV because the hemodynamics were not great, and we were worried about the AI, there's no AI on echo, but we got a double-digit gradient. So we decided to balloon the valve. We got a 26 millimeter Z-mid balloon, and we post-dilated the valve. And you can see the valve is touching the annulus. It's not necessarily a deep implant. It's not as high. We usually implant them a bit higher, but we thought it was an acceptable implant. And this is how it looked on TEE. And
Why did you why'd you choose a Z-Med? I'm just curious.
As opposed to true?
As opposed to a less compliant, yeah.
Yeah. We typically do them with with the Z-Med. We do not carry the true balloon, and we order them if we want to frac a valve. I'm sorry, Adnan, I used the word frac, but we usually not. The echo gradients were single digit. We dipped into the ventricle, and we got a mean gradient of 8, and traced to mild perivalvular leak. So at that point, we were extremely happy. The patient improved significantly, creatinine normal, decannulated the following day, got extubated in a couple days, and was discharged in 5 days later. 30-day follow-up, his mean gradient was 8, he had trace AI, his ejection fraction, I'll show you, I'm not an echo person, but this ejection fraction looks much better than the one I showed you before. And one thing we do, though, and I want to share that with the group, all the bicuspid that we do, we scan them. in follow-up. So if you, so we put a 34 millimeter core valve in this case in a perimeter that was 98. And the valve is functioning great at 30 days. And this is the CT. We have a, at that level of supraannular sizing that Jeff was gonna ask me about, we got a diameter of 24 and a 20. And this is a 34 millimeter core valve. So in conclusion, TAVR can be offered as a salvage procedure in shock patients who are on ECMO and Impella, and TAVR sizing remain challenging in bicuspid native aortic valves.
Very nice case. Yeah.
You proud of your fellow, Samir?
No, very nice. Yeah, yeah, outstanding case. The one thing that you may want to do, instead of using an Impella to unload, you can use a transeptal catheter from tandem heart and just use it from the right and left so that there's nothing across the aortic valve. So that system works a little bit easier and better. Both of them cost the same because they don't sell the left atrial cannula separate from the tandem heart. So you don't need the tandem heart, you just need the cannula. Right. But unfortunately, that is not. But outstanding case, yeah.
You can put a PA sump in there, and a PA sump will drain what gets past your cannula and decompress it.
Right.
Yeah, we would have ballooned that valve because you're on ECMO.
Exactly, that's right.
You're not going to hurt the hemodynamics, and you can predict your valve like this. Remember, 24 is what the size of the waist of the 34 is anyway, so don't think of it as 34 where you're scanning it. That's where the valve was. The valve's not 34.
Just to defend this, we get this all the time, is that you're on ECMO, but that arterial cannula is coming with pretty big force. So if you have AI and you worsen the AI, I don't think the ECMO is going to really help that much. No, the ventricle will blow up. So I think I'm just defending the decision. Just go ahead and get the valve in. I mean, that was a good way.
I mean, and we have cases where we ballooned we pre-ballooned bicuspid. I mean, we traditionally pre-balloon all bicuspid before core valve implant, and we still see some waste. We still occasionally have to post-dilate them.
Why not a bigger balloon? I mean, a 24 Z-Med's not going to go up to 23. That's not a great
26.
Oh, it's 26.
It's a big,
Okay.
yeah. We have
Great
a
case.
very similar case we published.
All right.
Great job.
How, Will Anderson's going to come up and tell us how he managed a difficult Lotus case to round out the valves that have been used in the U.S. And no one wants to wait till you see my
We have some
disasters.
room in the front if people want to sit
Yeah,
down.
there's a couple of seats up front here. I mean, I know
At least 7 seats.
there's a table in the corner. No one puts
There is a table in the
We're going to be
corner.
asking you questions directly, so don't let that be an impetus.
I'm going to give you a spoiler alert. This is not a Lotus case. We didn't have a suitable Lotus case to show you. So Paul's response to that was, we'll show any case you want. So this is actually a Sapien case. I have nothing to disclose for this. So this is an 81-year-old gentleman with clearly very severe aortic stenosis, quite symptomatic with heart failure and left ventricular dysfunction, moderate pulmonary hypertension, some coronary disease, a history of bladder CA, COPD, et cetera, and was deemed not to be a very reasonable surgical candidate, was admitted with acute heart failure. Here's his parasternal long, moderate LV dysfunction, peak and mean gradients across the valve of 102 and 65, valve area of 0.5, moderate MR, and some RV dysfunction as well. Seemed like a reasonable thing to do. Here's coronary angiograms. Probably project a little bit small, but he's got a little bit of left main disease, but nothing to write home about. There's a patent stent in his proximal circ, and sort of a codominant system here. Fairly large distal circ. CT scan, his area was 463 in the sizing range of a 26 millimeter S3, which is what we had planned, and fairly deep sinuses, 31, 30, and 29. Coronary height's okay, left coronary 15, right coronary 17 and change. If you look Again, though, even though it's 15 on the left, he's got this snowball of calcium sitting on the top of his left coronary cusp there. And we measured that and found it to be 15 or so. And we were concerned about that. So we brought him to we do these in a hybrid OR. This was a case done under general anesthesia. We did a BAV with a 23 balloon and injected and saw coronary flow bilaterally, approximately equal coronary flow. And it's the usual coronary flow you see when you're rapidly pacing, which is not normal. But he had coronary flow, so we thought, okay, we'll put in the valve, not going to protect, which turned out to probably not be such a great decision. We put a 26 in, and it was a very uneventful case. Rapid recovery from pacing run. With the valve in place, he looked fine, no change in his LV function, a little PVL along the aortic mitral curtain, but nothing to write home about. Post-procedure, of course, he had a transient left bundle. We diuresed him. Echo the next morning showed a mean gradient of 10 across the valve. Again, moderate LV dysfunction, and ended up going to a sniff post-op day 4.
Do you routinely do an aortogram at the end of the procedure?
You know, we do for conscious sedation cases, Jeff, but typically not for if we've got a TE probe down and our hemodynamics are okay.
Okay.
Um,
Sometimes it helps you if you're worried about coronary access and all that. It helps you at least know what you can tell your partners in the middle of the night.
Well, and I think we would do this a little differently this time. We did manipulate the valve a lot.
You had no concerns, right?
We weren't. I mean, we weren't concerned, but that was naive. And I tell you, our conclusion was, look, left ventricular function's fine, ST segments are fine, the guy hemodynamically is fine, transvalvular gradients look good, and we thought, okay, one of the many coronary takeoffs that you worry about, and frequently we protect. In this case, we didn't, but it seems that protecting means that you don't have to do anything and you pull everything out at the end of the case. So he goes to sniff, comes back on post-op day 7, chest discomfort, palpitations, he's in rapid AFib, gets cardioverted in the ER because he's hemodynamically unstable. He continues to have persistent and pretty marked ST depression on his electrocardiogram. Trope comes back at 3.5, so off to the cath lab we go. Here's his coronary angio. And I think, I don't know if you can appreciate it, but you guys may be able to see this on the dais because you have a bigger monitor, but you can actually see this kind of rock of calcium in the left cusp sitting up against the left main and really impinging on it. Here's his IVS, and I apologize, I didn't have the capacity to edit this, so we're going to spend a few seconds here in the distal main, which is not particularly relevant, but some fibrocalcific plaque there and a little bit of artifact. Now, this is the manual pullback, by the way. So, and as we come back, you'll really see that there isn't much to suggest that there's thrombus here. There's a little bit of, right there, you can see a little bit of fluttering there. That may just be flow in this externally impinged upon left main. But I didn't really get the sense that this was much about acute coronary syndromes as much as it was about rapid AFib and impingement on the left main. So we got a 3.5 DES, and with serial IVUS, we went back with 4.0 and 4.5 balloons. So is this a case of delayed coronary obstruction? You know, there's a little bit of literature on this, and it's clearly a rare event. I think this is probably immediate coronary obstruction that we didn't recognize. And I think we either should have done an aortogram so we could see the left main, or frankly, a coronary angiogram to see the left main. But for the purposes of the discussion, we did have a few risk factors in this setting. This is a very heavily calcified valve and calcium in the wrong places. And I think our device position was a little high. We manipulated the device a lot, and I don't know if you appreciated it during the deployment of the valve, but really we had pulled the wire back. We were on the inner curve of the aorta. We were a little tangential, and I think our valve positioning was slightly high. But my guess is this really isn't, look, I think from a clinical perspective, in a de facto way, is this delayed coronary obstruction? Sure. I mean, patient gets out of the hospital and comes back with coronary obstruction. But I think actually the coronary obstruction was probably there. We didn't do an angiogram at the end of the case, and I think we probably would have benefited from that, or he would have benefited from it. And I think probably this is demand ischemia more than anything with his rapid AFib. Does share some of the DCO characteristics of a high valve implant, marked calcium of the left coronary. As I said, this is a very low frequency event. In Joe Boer's paper, it's 0.22% overall, and others have described similarly low event rates. And I think actually in these data sets that we're acquiring, particularly with TVT registry, I think we're going to be able to look at this a little more objectively and figure this out. Thanks very much.
Yeah. I would just say, I'm not sure the height of your Sapien, whether it be a little lower, is going to change that, right? You have open cells up there. That's a leaflet length calcification, because if you dropped it way low, you don't think that stiff thing's going to...
No, I would totally agree. And really, just trying to draw some parallels to what we're thinking about from the literature as DCO, I don't really think this was DCO. I think it was just uncovered at a later time because of clinical events.
I was going to bring my case was very similar one where we IVISed it, we protected it, we left. We thought that the leaflet was fairly away from it, a little bit. And so we left it. And while in the cath lab, she dropped the pressure, ST segments, and we stented it, and she did fine. But my point is, it's not very easy. This was an extreme case. But you can have intermediate case where you can have a leaflet which is close enough to the left main, but not quite inside of it, and you don't know what to do, and most of the time they do fine. So there is no real good reason to stent all of those. So this
we've had a couple cases where everything looks fine, patient is fine, but we can't pull the stent back because it's partially obstructed. It's partially obstructed and can be difficult to appreciate. Aortogram, even we put a guide catheter down and took a picture and we couldn't see it, but we knew that we had to fix it because...
No, the reason why it doesn't come out is because the STJ and S3 valve are close to each other. So if you measure the height, and if it's less than 16, the STJ, then it won't come out. So these days, what I do is I put a guide liner in all patients. Right. And instead of, if you're not 100% sure, you can put a balloon and then cross back from the S3. So at least the stent will be straight and not chimneyed, because this way the stent will be chimneyed. So those are but it's a controversial area.
But soon enough, you'll be splitting all these, and then...
That's right.
So my one question was that one important thing to know is that if you don't have sinus flow, so when you look at your coronary angiogram, you don't see any flow in the sinus. So if you don't see any flow in the sinus, this is a very high risk for thrombosis. Right. So even though you didn't see thrombus, it's very possible that there was some thrombus in that area because there was no flow in the sinus. So if there's no flow in the sinus, this is an important thing because of the very large calcium. Otherwise, you should have some drainage in this sinus.
All right, we should move on. Will, that's great. That's great. Thanks, sir. So, Samir, we have you one beat here, Dr. Reardon and I do, because our next speaker was my fellow, and then he went to be Dr. Reardon's fellow, and now he's across the street from you at Case Western. Is Ankur here? Ankur Kalra?
Friends with me, yeah.
There you go. Well, so welcome. We're very proud of you. We're very proud of you.
So thanks for the opportunity. I don't know if this is bad karma or if this is a pre-planned annihilation, because like Jeff said, I was his fellow and then I was Mike Reardon's fellow, and now I'm up here presenting a complication.
That's because you're in Cleveland. You're in Cleveland now. That's why you have a complication.
But nothing to do with me. But it's fine. I'm just joking. He's friends with me.
So I guess it's bad karma. We'll take it. So just all of you just have me in your thoughts. So it's just moving on to the presentation. So I was given the headline of TAVR complication surprise, and I'm not sure if it was that much of a surprise in retrospect, because obviously retrospect, hindsight, it's 2020. So our case is a 97-year-old gentleman with a past medical history of abdominal aortic aneurysm, status post-endovascular repair in 2015, complicated by a type 2 endoleak. Had severe mitral regurgitation, was treated with transcatheter mitral therapy with a mitral clip device in 2015. The post-operative echocardiogram, this is following a mitral clip placement. His LV systolic function is 55%. And there was a reduction in MR from 4+ to 2+. And at the time, aortic stenosis was moderate at best with a mean gradient of 20. There was a decline in functional capacity for the past 6 months with dyspnea and exertion with minimal activity, New York Heart Association class 3 symptoms. So the repeat echo in 2016 showed an EF of 50%, a mean gradient of 28, so a mean gradient went up, a valve area of less than 1.8, and a dimensionless index of 0.21. I'll add here that I have not written it, but the stroke volume index was less than 35. So by definition, could be considered paradoxical low flow, low gradient severe AS. And had moderate tricuspid regurgitation with an RV systolic pressure of 63 estimated on echo based on the tricuspid regurgitation jet. So these are the images from the repeat echo in 2016. As you can see, mitral regurgitation, it's moderate. There's a clip in place, and then there's moderate tricuspid regurgitation as well. So ECG showed normal sinus rhythm, baseline right bundle branch block, hemoglobin of 10.5, creatinine of 1.9. And the heart team decision was to proceed with transcatheter aortic valve replacement based on risk assessment from the Society of Thoracic Surgeons risk score, advanced stage frailty and renal impairment. This is his pre-procedure angiogram, so no evidence of obstructive coronary disease. And that's the CT scan. Okay, that's good, it's playing. So it's the CT scan to assess for femoral access. So just pay attention to when the femoral head is displayed right there. And then you could see the access on both sides. So fairly good access for a transfemoral case. And this shows the tortuosity of the aorta. It's a 3D reconstruction. Now the perimeter was 77. The sinuses are large, 34, 35. And my question to the panel is, what do you think should be the choice of valve and also the approach? I think we briefly went over the approach here, but what do you think?
I would say very tortuous aorta, put a S3 valve, easier to put on.
There's a lot of calcification of those femoral arteries. I thought maybe towards the top of the left femoral head might be the best spot to access.
See if that plays again.
But it's not too bad, it's access.
Yeah, I'll just play the multiplanar reconstruction again.
I have a simple solution for that, because if they can do EVAR, you can do a TAVR. So that is, because you're more sophisticated and smaller size.
Here, the anterior, right here at the top of the femoral head, the anterior portion of the left femoral is okay.
Yeah, I think this cut down and sutured and all that. So you can just go above it. Whereas I think this is...
Okay.
Actually, so given the complication I'm going to talk about, we'll say maybe it was not a good idea to do a subclavian. But so, it was, so we went in with the choice was core valve. This is just a run of the fluoroscopy for you to appreciate the degree of tortuosity.
Okay.
And
That's an Evolut?
no, this is an Evolut. It's a resheathable Evolut, not the Pro, but Evolut R. It's a 29 Evolut R.
It doesn't look like you used a Lunderquist wire to help you get up either.
No, this is just a Safari wire.
put you across, and it looks, no trouble going up. It just tracked everything through, no resistance.
Yeah.
Watch the nose cone, make
Yeah,
sure it didn't separate from the capsule.
And most of our cases, we do sheathless, so we dilate with a 16, and then we take the 16 out, and then we go sheathless. And, under fluoroscopic guidance, it went all the way. It was tortuous, for sure, but then it went, and we assumed really good position, as you can see here. And at the time we were actually at this position, patient developed sudden hyperventilation, and there was a suspected, we thought this was an acute stroke at the table. So obviously, we had to stop what we were doing. We called anesthesia. The patient had to be intubated, and we got the valve. The valve was across, so we had to actually, just recapture the valve, pull everything out, and stabilize the patient first before thinking of doing anything else. And then we decided to switch to, as Dr. Kapadia mentioned earlier, S3, because we didn't want to deal with the tortuosity again, because it was painstaking to get to that point, and unfortunately the patient had a stroke. So our next valve was a Sapien 3026, based on an area of 435 millimeters square. And this is the Sapien getting deployed. No issues in deploying the Sapien valve at all. And then the post-operative course, so the echo showed that the TAVR valve was well seated with trivial aortic insufficiency. There was no effusion. And then the CT of the brain vessels demonstrated that there was a basilar artery thrombus. And actually a mechanical thrombectomy was performed, but eventually the patient succumbed to the perioperative stroke. So we think maybe in retrospect we could have just gone up with the Sapien to begin with, to avoid all the manipulation at the level of tortuosity. Although the recent analysis from the Sentinel disproves that theory. It
or you could use Sentinel too. That's another thing that you could use cerebral protection.
Yeah, but
Right.
How it went there is a question, but yeah, anything is possible. But the way the aorta was is very unlikely. It went like.
The guy hadn't got hypotensive, you'd have done fine for you. It was going
Oh, sure.
It was doing fine.
Yeah.
You could go either way. You could have gone in some Clayton. You might not have had this. You went in some. Who knows? These things.
Right.
Yeah.
Right.
It's maybe it'd be 6 of one, half dozen of the other.
What could have happened from a subclavian approach too, though, right?
Clayton approach,
Yeah.
you could have a carotid approach. It looked to me like you had a pretty good position. You were doing great.
Yeah.
And then the guy had an acute event,
Mhm.
which could have happened with anything.
Sure.
Well, that's great, Ankur. I mean, and I wouldn't, these things happen with every single case, right? So we've had strokes. And I guess we're becoming more convinced that Dr. Kapadia is correct, that we should try to think about defaulting to some device that is going to provide cerebral protection. There's certainly a number that are in the works, but I actually don't think it was an issue of the Sapien versus the Evolut for getting up and around. I think you probably would have still been maybe easier, but you still would have been navigating the same territory with the Sapien.
Yeah.
So that's good. All right,
Okay, thank you.
Yeah,
Steve, where'd you disappear? Oh, you're over there now. All right, Steve Yakubov is going to tell us about complication success. Is that an oxymoron?
Where would I be?
there you go.
All right. I've had the opportunity to be doing TAVR for 7.5 years, and every time I protect the coronary arteries, I never occlude them. And I've had the opportunity to be part of 4 cases which have occluded the coronary arteries. So this is my 3rd case. It was an inoperable case, a 72-year-old woman with an FEV1 of 23% predicted. And it was probably a bicuspid aortic valve, not perfectly aware of that at the time that we started the procedure. Heavy calcium, bulky valve, and again, just my 3rd case at the very beginning of the core valve trials. And we certainly clearly did not know enough not to do the case. It was a proctored case.
It's a rolling case too, thank God.
Yes. And so we did a balloon valvuloplasty with a 20 millimeter balloon without difficulty, and then a 26 core valve was deployed, and then all the fun began. She became suddenly hypotensive. There's quickly no cardiac movement noted. She had really poor access in her femoral arteries too. It's just surprising we can get the device up the legs. And so now we're off to the races. So this is, so while one of my partners was working on femoral access on the other side, and it was too small for CPS, we clearly would have ripped open the artery. A balloon pump was started to be placed, and I put a JL35 diagnostic catheter into the coronary arteries after that initial angiogram, and lucky enough to find where the os of the left main was. I did try to put a guide in, but I couldn't get the guide to fit, probably because I didn't know what I was doing. You know, I didn't know which guide to use at that time. I wasn't really sure what the heck to do. So I went back with the JL35 because I figured I can get that in. And flow was restored. Blood pressure wasn't the greatest, but flow was still restored. And so to get a guide in, I put a, once the artery was wired, I exchanged it over a balloon for a, I think a Grand Slam wire was what I was using. And then I was able to take a guide, do a guide exchange over the coronary catheter and put the guide in place. And this is, I think I still didn't know which guide to use at that time. And you can see here, it's probably not the ideal guide situation. It's coming from a little below. It's not bad, but it's still coming from a little below. And the lesion was identified. So finally, a 3.0 guide was placed over the Grand Slam. A POBA was done to better restore flow, and then a 4.0 drug-eluting stent was placed at high pressure. And again, at this point in time, I really didn't know if I should try to snorkel part of the stent, land it perfectly, land it on the other side of the, I didn't, so I just kind of did whatever I felt like and put a drug-eluting stent, lined it up where I thought the os was. There's probably one strut hanging back into the core valve. I didn't know if I'd be interfering with the valve or the valve would interfere with it, and then used a 5mm balloon at the end and post-dilated it. And stent wasn't perfect, but here's that post-dilatation. That's the final result, and that one worked out okay. So after more experience, I can tell you the sequence of events over the 4 cases that I've had. When I got to the very last one that I did, now there's an aortogram, and then there's a picture of a coronary artery. So I skipped all the other steps in between, just because you're working so fast. But this is a 78-year-old man with a mean gradient of 42, valve area 0.8, very poor walk time, terrible COPD, and he was still intermediate risk despite all that. You can see here some of his annular dimensions. He was I was going to show you the coronary heights, which weren't very impressive. Coronary heights were, I think, 15. I had no indication that that these coronaries would occlude. It was an uneventful deployment here where at 80% you could still see the coronary arteries filling. Looks like a good landing zone, relatively high implant, and then of course, no movement. So now you can see the CPS cannulas in place. So this one had adequate circulation of the legs. We quickly put them on bypass while the other person was working to get the coronary arteries. No flow, no left ventricular function, a total occlusion of the left main. Once in a while, it's hard to find out where the origin of that left main is. This time I knew to put in a JL30 guide. And one thing that I've found is often you don't exactly know what's occluding these coronary arteries. It could be thrombus, I guess, but typically our ACTs are very high. It's usually leaflet tissue, and it's often hard to poke through there if the left main is flush occluded. And so this one required a confianza wire. Once that wire was down, it was exchanged for a Pilot 50, and it was down this, placed into the OM vessel. And flow was established, the vessel was stented, but the patient was still not doing so well. The blood pressure was still kind of hanging out there, not so good. And you know this patient has prior bypass, and you usually think of these patients, you get away with everything because they have some circulation, there's a network of collaterals. You never really get into trouble in these patients, except for this guy. And he's still no good even after opening this vessel. So I had to go back and look at the coronary angiogram again, and there's another OM I've just stented across. Now there's 2 stents across a high OM. And since he still wasn't doing well, I just figured I'd stay in there and play with that for a while. And so I wired that other OM. Now that's through 2 stents that os comes through. That was ballooned and stented again. He did great when you open up that other OM. So you don't always exactly know what has to be fixed all the time. And thinking you get one vessel done is often not quite enough. And just so that you know, I'm an equal opportunity occluder. This is an 83-year-old with an STS of 5.3, and it's an S3 valve. I don't only occlude with core valve, I can occlude with anything. So this is a 26 S3, uncomplicated valve deployment, and then all my sadness starts right here. And so I got everything on this one. Actually, I take that back. The right was chronically occluded. So that was a chronic, totally occluded right that looked like that before. Thanks, Adam. No blood pressure, no cardiac movement. Put on CPS again. Difficult to wire. Finally got a JL35 guide and a Pilot 200, and a guideliner was placed. Samir just talked about the guideliner. I think that's great,
That's
especially.
clot, though, right?
You think that's embolization?
No, I think that one's clot. I think that one's clot. But it's hard to tell then. You know, all my
Well, but you're above the cage.
yeah, all my previous experiences with valve and valve tissue, so I always suspect valve tissue. Maybe I embolize it, maybe something else is going on. But I think this one was clot. So I thrombectomized it, got some improved.
I think there is a valve tissue. You see that little thing flickering right at the ostium, and that's what caused the thrombus.
Yeah, so it's tissue.
Tissue.
Embolization leading to thrombosis.
You see that little valve that is there in front of your...
I have everything on this.
Okay.
Yeah. So daughtered it, thrombectomized it, balloon inflated it, nitro, you name it. And so finally I put a stent in it, and we got normal flow with better LV function. So just the lessons learned. Coronary artery occlusions are rare. They're difficult to predict. And so the only ones I ever have are the ones I haven't protected. Hemodynamic support often is necessary, but it has to be really quick. And I think that if you don't get the coronaries open by angioplasty, the patient isn't going to survive. I don't know of patients that you'd really have enough time to get to it has to be a special case that you can open that chest and put bypass to it. One thing is if you have a core valve and you occlude the coronaries, one of the quickest ways out is just to snare the valve, pull it up, or get a big balloon and pull it right up rather than messing with the coronary arteries, especially if you know you're going to struggle with bypass. And always remember to use stiff wires. Guide catheters are really helpful. If they're not the geometric designs that come from the bottom with core valve, I think you have to use guide liners through there. You're going to get trapped on this with the stent or taking the guide catheter out at the end. So in those instances, I clearly would use guide extensions. Anyway, thanks.
Good, thanks.
Yeah.
So, since you use, I don't use as many core valves as you do, I wanted to know that if you wanted to protect the coronaries with the core valve or Evolut, and if you're behind the, valve, is it enough to just put a stent behind it, or how does it work? Do you have enough cases or literature to write it up or something to say how do you protect it?
Yeah, to snorkel it back.
You mean just to put the stent behind it?
No, I'm just asking what is the bailout. So let's say you have a core
So if
valve.
you're going to protect, everybody has a little bit slight different method of protecting. When I protect, I have a guide, a wire, and a guide liner. I don't put the stent down. I figure if I need the stent at the end, I'll put the stent in, so I don't waste the stent. Now, some people say if you're going to protect, you may as well stent on the way out. I don't know if that's right or not. Regardless, they do that. I don't. I have a wire down. I have the guide liner in the coronary artery, and I try to intubate the os with the guide, thinking that that's going to block any passage of valve up into the os. And then I take everything.
You're still behind the whole structure.
Yeah, you're behind it. Yeah.
So how high would you recommend now that you take?
Well, then I would snorkel the stent just outside the os, because typically you're behind it, but you're behind the valve too. Yeah, I think that you would get paravalvular
blood flow and diastole. I don't think that's a problem.
So you're saying, right,
Yeah.
but if you're saying you don't have to get above the commissures of the
No.
TAVR
No.
leaflets?
Only if you're below the skirt.
Yeah.
Then you have to TAVR it up to the skirt.
Yeah, I think it's a little confusing when we use the word snorkel, because I think people think that you have to stent
All
like
the way
up to the
up.
STJ or
Yeah.
something like that. It's just pushing the leaflet out of the way, same as with a Sapien. You're just pushing the native leaflet away from the ostium.
Yeah.
It's not like some big
There's,
snorkel.
there's typically a lot of room behind the valve most of the time.
Let's give you ever any cases where you have your guideliner in there and everything looks great, you pull the guideliner out and it was holding the valve down, then the valve goes up?
I haven't had a case like that. You know, that's why I think some people take the position that if you're going to protect, you may as well put the stent in and deploy it at the end, that they're that concerned. I haven't done that. I just put the wire guideliner. I haven't been burned on pulling the guideliner out, and now you have a real problem. But that can happen. I do like this.
So for sometimes for the Sapien, what I do is I'm behind.
Yeah.
I leave the guideline, then I put a guide from the valve sheath, big sheath, cross back in from the valve, and then remove the other thing. So I am certain that I'm not holding
you're
back.
okay. Yeah.
And if I need an access, I can. And that stent is nicer because it's not behind. It's like what you just did, that it will come back into the stent. So that way the coronary guideliner, everything is there. We have an access, big access in the groin anyhow. So you can go and put a guide and wire.
That's if things are stable.
That's just, if everything is stable.
I do think that when you talked about taking the angiogram to assess the sinus flow in those instances, that's really important.
Sinus flow is critical,
Yes.
I think,
All right, good. I think we're going to wrap up with Dr. Greenbaum, the last one. My approach to CTOs. No, I'm just kidding. Difficult transcaval case.
Yeah, so I've spent the last 5 years actually trying to show people that this isn't a difficult procedure, so I'm a little hesitant to show. But for those of you who know me really well know that I'm willing to show all my disasters. So that is not a problem of mine. Here are my disclosures. Let me start by saying that there's been over 600 cases done. It's the most transfemoral-like of all the alternative access, and there is a high success rate with minimal complications. I mean, this is a safe procedure, but the fact of the matter is there's certain anatomy that can be challenging, and there are still some contraindications. Real quickly, because I get asked this question all the time, is can you do the procedure if the vein's occluded because you have to go from the right? And the answer is sure you can. I mean, here's a case where, I don't remember the story, but for some reason their pacemaker wires had to be pulled down to the leg, and there's a pacemaker in the groin, or I should say in the belly. But so it's completely occluded. So just recanalize it with a wire. Everybody here knows how to do CTOs, IVUS, and make sure that you think you're in the architecture of the vein, but I don't know why you wouldn't be. And then go ahead and balloon the thing open and just get your big sheath in first so that you now know you can at least drive the big sheath in. That's a flex. That's a Gore Dry Seal Flex. And then go ahead and do your transcaval through the big sheath. So that's as opposed to putting it in after you cross. And then, of course, at the end, just close it like you normally would, and everything's hunky-dory. And then we got to bill for venoplasty as well. Okay, so how about one, though, that doing a transcaval and one that you know you shouldn't do? So I was asked to do this transcaval, being told that this was a spot that you could go. Look in the upper right there. You know, you'll hear me on a lot of these talks say I love to go through where there's ectasia, but that's not ectasia. That's like a piece of calcified popcorn or something, which turns out to not be the case. So here's if you look at the angiogram, can you see on the right here as we rotate, this is a really focal, heavily calcified. Now, there are three things that go against transcaval here. One is the actual window is tiny. Number two, the calcium juts out here, and I like to go in the bottom third of the ectasia because that's the way the disc is going to come down, but the calcium's completely wrong, so you'd have to go on the top third going around the top. And then the ectasia is not big enough to allow the device to come back. So sure enough, I actually said, we're not doing this one transcaval. We're going to do everything we can to try and go transfemoral. So plan was to use a core valve. So we figured we'd dial up the iliacs, but we couldn't even get a 16 French dilator up the iliacs at all. There we are struggling. Took an 8mm PowerFlex balloon, tried to get a 16 sheath because we were going to use an Evolut Pro, right? And you want a 20 French outer diameter on this sheath. Was able to get a 20 French Edwards dilator up, so we said, all right, let's try the core valve. And no-go on the bareback core valve. That's as far as we could get it. The ballooned it again, really high pressure, tried to get a bigger dilator and a 22 Edwards dilator and just could not, and said, all right, let's go back to the procedure that we knew would likely be a disaster. The burn's not the problem here. You're going to get across because it's like threading a needle, right? If you're in the right spot, the wire's going to go across. Here we are snaring it. And then we drove it up. But here's what's interesting. We get the wire up, we get a microcatheter up, we swap out to the stiff wire, and I can't pull the microcatheter out. And if you look on the right here, the explanation is where we've actually, such a stiff wire has taken those two things of calcium and actually made handcuffs on the thing. And at least we were smart enough to say, whoa, if we pull really hard, we're going to leave some catheter in the body. So we backed down to the softer wire to actually get the catheter out. But now you got to try and deliver transcaval stuff through a tiny hole above some calcium with a soft wire. And as you can see, this is a disaster waiting to happen. We can't even get the balloon in to do a balloon deal. We eventually do it, 3-millimeter balloon. And here we are trying to push a catheter across something that, just don't try that at home. And eventually taking a Cook check flow and pushing really hard, we did get it to go through. So we were able to get the sheath in and get the core valve in. And Jeff, did I do a good job here on the core valve? It's like my first one. I don't know. Okay, so now we have to close this thing.
You have a future in core valve, Adam. You have a future.
Well, okay, good. So now here's, you can see the problem, right? The plug's not even going to fit in that little tiny spot. So we're getting it as close as we can here. And here we are going to passively expose it, right? So we'll pull it back to propose the neck. But again, you want to get this thing up. So the pressure starts to drop despite protamine. Now you got bowel, kind of shifting bowel. It's hard to tell if there's any bleeding or not. So we said, let's just, pressure was a little soft though. So if the pressure's soft, you assume that there's bleeding. So here's a reliant balloon. Can you see the weird sort of Weebles wobble shape of this balloon, right? It's because the balloon's filling up this tiny little crevice. That's not really the ectasia that I like. Despite multiple inflations, the pressure's still soft, and now we think we have a dissection on the top of that pouch. So we said, well, let's go ahead and put in a graft. And here's a trivascular iliac limb extender. These are self-expanding covered stents, but it's only 45. And so then you could also predict, well, when it's so short like that and it starts to sausage into that little pouch, well, now the ends are bent inwards, so you're not getting the seal that you really want to get with these grafts. So here we are trying to dilate the thing. And in the end, we're like, it's not the best, but the pressure got a little better. So most of these people do okay. And in the end, patient did okay. Here's our final angiogram. You see that little pouch coming off there. There's just not the good flow that you like to see in the IVC. Patient actually came back on day 12 with some back pain. Actually had nothing to do with anything, but we CT'd them. And this is the classic appearance of what that pouch looks like on CT scan. It's sort of a little endoleak. These all heal over time. This patient did fine, but you could predict that this was what the CT was going to look like, and you could predict this complication based on that. So a couple things about CT scanning for these. So, here's the goal. Find a calcium-free spot. Avoid the obstacles. Identify some branches that might be in the way. I mean, these are the goals of CT planning. You have to have a big enough hole to get the sheath in. It has to be able to open a little bit. You don't want bowel. You don't want calcified dissections like this patient. You cannot do that shaggy aorta that's in the middle there. And if it's a really leftward-leaning aorta, you're going to skate through the wall a little too far. So we like the rightward-leaning aorta, not the leftward. Make sure you're above grafts, things like that. These are things that all make sense. And so in the end, and then know what you need to do. Know how long an endograft you would need if you get into trouble. And then, of course, map out where you're going to go. So in summary, most patients are candidates for transcaval access, but there's a few cases that are predictably unfavorable. I mean, in this case, look, we tried as hard as we could to get across without doing it. And there are some helpful tips and tricks in these situations. And look, we still got away with it. Actually, the patient did fine, but it's not one that I recommend that you do early on. You got to understand how the CT works and how to find a spot, select these calcium-free targets, and then ask for help. And we're happy to get you started. Thanks.
Great, thanks.
So, Adam, the stent graft is 14 French, right?
Yeah, so that's a 14 French.
Right.
Well, we've been up with 22
is,
French dilators, right?
No, but my point is that if you can put a 14 French sheath, you could potentially... do
Not necessarily, right? I mean,
No,
so
because
so the
I don't know.
Endologics iliac limb extender is a 12 French capsule. It's pretty hydrophilic, pretty slick. You just need a 3 millimeter vessel to get it up there. And you could just balloon real quick if you needed to. And so I actually find that that's not necessarily true, that you can deliver a covered stent to places that you can't deliver a core valve to.
Could you,
or go ahead.
no, finish.
You use, I know that nobody likes to hear that, but is it possible to put a core valve through the E-sheath? Because I do
Yes.
it. I
No,
have
it
done
is-
it, and
yes,
it
it is
works.
possible.
But of course, it's very hard to find it, and
Yes.
people get a little bit anxious with that.
Sure.
But
you can do it.
you-
But
but-
you wouldn't get a knee sheath across that thing either. So.
Adam, could have you used a different closure device? I mean, was that?
So that was, I think, was that a 10.8 or an 8.6? I mean, there's an 8.6 and a 6.4, but again, you might look, you got a 20 French sheath across with a 24 French outer diameter, and so you need to have some compression, and that's not going to recoil, right? That's a calcified piece of, that's an ulcerated, defect in the aorta. Again, that's not the ideal place to cross, But that patient does fine, so it is doable. It's just not what you want to do on a regular basis. So.
All right, everybody. Listen, I thought those were amazing cases, guys. Thank you so much. Thanks, good audience. We're right on time, so thanks for coming.